Good afternoon, everybody. At the outset, I like to thank the organizers for inviting me. Next 15 or 20 minutes, I'll take you through a journey of pharmacotherapy. I think Dr. Makkar, Dr. Singh, and Dr. Shilpa Joshi have laid a good platform for my talk. I'll be taking off from there. This has been already covered, telling that obesity is going to become a big burden, not only in the form of a weight and also in the comorbid diseases. This is what has been happened over the years. In the past, obesity was a rarity, that's why it was worshipped. Now, leanness is a rarity, that's why it's getting worshipped. That's why we are getting size 0, size less, and other things. Most important problem what we are facing is a teenage obesity, which is leading to adult obesity and subsequent complications. What genes do and what environment does is, genes load the gun, whereas environment just trigger the gun, so that there is an explosion of obesity. That's why pharmacotherapy becomes most important. The prevention of obesity is very important, but it's very good to talk, and it's just a strategic imperative. But by and large, as the ages, if physical activity is not going to increase, your eating activity is not going to improve, obesity sets in. Treatment of patient is the most important, because that's why they present to the doctors. We need to use agents which induce weight loss, that is true, and also we need agents which maintain the weight loss, what has been achieved with the weight loss programs. Unlike bariatric surgery, which is quite less number of patients undergoing, quite expensive, pharmacotherapy offers a much better option. So what is the position of this pharmacotherapy in obesity treatment? I know lifestyle management is the most important, but most of the lifestyle management programs do fail over the period. So also to some extent even pharmacotherapy. Most patients regain whatever weight they have lost with a lifestyle modification. Hence, pharmacotherapy becomes one of the important and a useful tool to treat patients who have failed on lifestyle modification. There are a lot of expectations when patient comes to meet doctors, and also there are lots of expectations from the doctors from the anti-obesity agents. Patients and clinicians expect there is lots of difference obesity agents do to the patient, and they are often difficult to fulfill, because we do understand etiopathogenesis of obesity is a very less understood thing, and lots of hereditary factors do play in the obesity. And personalized therapy for obesity is quite difficult at this stage. What the clinician expects from the anti-obesity agents: patient should lose weight. That weight loss should be in the form of a fat, not the muscle, and preferably he should lose visceral fat, which is metabolically very active. He should not only lose the weight, it should also correct the metabolic needs, which happens with the visceral weight loss. It should be, side effects should be very minimal, and it should be orally available, and it should be at an affordable price. These are all idealistic expectations, very difficult to meet. But what patient expects from your anti-obesity agents is, most of the time we are happy if patients lose 10% of a body weight, but patients want to lose much more than what is being expected from clinicians. There are lots of barriers for this anti-obesity drugs. Very few drugs available for a treatment. Less than 3 categories of a drugs which are clinically useful, though there are plenty of categories of a drug. Poor understanding of etiology of obesity makes us difficult to treat. Typical weight loss achievable in most agents with clinical trials is about 10% of the initial body weight, and very limited use of the combination therapy. Even a regulatory approval is quite difficult with anti-obesity agent. FDA and European agency do differ, and they retain an absolute right on the product and its licensing, irrespective of the clinical results. So there are a lot of obstacles to develop a new drug. They are not financially rewarding, because 100 molecule get studies, only 1 or 2 gets into the market, that too for a few years, and many gets banned over a period of few years. They are not covered under insurance in the US. Even when it's covered under insurance like Europe, it is not being widely used, because high expectation from the clinicians and a high expectation from the patients, and patients do use for a very short period. Mainly we have got 4 classes of a drug. One which reduce energy intake by suppressing your appetite centers, increase the energy expenditure which is peripherally acting, modulate the fat storage, and mimic the caloric restriction. Under two broad categories, we do classify the drugs. One, centrally acting at the hypothalamus, mainly on the arcuate nucleus, enhances the satiety, suppresses the appetite. Peripherally acting agents, to some extent, your thermogenesis and also to the lipase inhibitors in the gut. Yeah. So the first therapy in the pharmacotherapy of an anti-obesity agent, patient should follow lifestyle management for 3 to 6 months. If there is a failure of a lifestyle management, then only you consider treatment for such patient. And the BMI is more than 30, that is for Caucasians, more than 25 for Indians, and more than 27 with comorbidities for a Caucasians, more than 23 for an Indian, should consider for a treatment if they fail on a lifestyle modification. This is the history of a pharmacotherapy for obesity. Thyroid hormone being used in the past in 20 or 30 years back. Now to the sibutramine, all drugs have come for a use for a short period and they have gone off the market. These are all the classes of a drug which are being studied, more than 30 or 40 agents. I am not going to take you through all these drugs, but what I am concentrating on these 5 drugs which will be available in India in a sorry. Some of it is available, some of the drugs will be available shortly in India in few years. The first of the drug which is available is the orlistat. It inhibits the intestinal lipase, approved for use in 1999, and it was made available in 60 milligrams over the counter from 2007 onwards. It acts by inhibiting the intestinal lipase, reduces systemic fat absorption, hence fat gets excreted and patient will be having a steatorrhea. The efficacy is a modest. Patient loses less than 5% of a body weight to the tune of 2.8 to 3 kgs over a period of 6 months. By and large, it pinches more your pocket than your fat. Yeah. Then comes the next class of drug, that is lorcaserin. It is just serotonin 2C receptor agonist, officially approved by FDA in 2013. What it developed to exploit the beneficial effect of a fenfluramine which was available in the past and it went for a ban. It removes the unwanted side effects of fenfluramine and gets only a useful and useful benefits of fenfluramine. Its efficacy and safety has been studied in more than 3 trials. One such trial was a Bloom trial wherein they used more than 3,000 obese subjects. They randomized for a placebo and a lorcaserin. Initial use for 1 year, subsequently there was a placebo for 1 year in one group and a continuation of a lorcaserin for a second year. What they found was a most thing. There was a good weight loss when they used lorcaserin. At the end of 1 year, one group discontinued. There was a steep increase in the weight gain. The group which continued, they continued to lose weight. But there was some amount of regain at the end of 2 years. At the end of 2 years, there was more than 5% of a weight loss. One more trial which it was studied was a Blossom trial, wherein more than 4,000 patients did use lorcaserin and show the benefit. What are the benefits with this drug? It is used in 10 milligram twice daily over a period of 2 years in the clinical trials, close to 5.6 kgs, which comes close to 6 to 8% of weight loss. It not only reduces the weight, it also has got a beneficial effects on the metabolism in the form of reduction of LDL, weight loss and reduction of HbA1c. There are certain side effects in the form of headache, your nausea, fatigue and dizziness, but there is no incidence of a valvopathy which was seen with fenfluramine, excuse me, nor there is a incidence of a hypertension. Long-term CV safety effects have not been studied, but however they will be doing a study. But there are little concerns about lorcaserin. The incidence of a mammary adenocarcinoma was increased in a female rats when they used in the doses more than 87 times what has been studied in the human beings. That's not going to be used anyway in the humans. And neuroleptic malignant syndromes can be a risk if it used along with the MAO inhibitors and other antidepressants. However, we won't be combining both. Next class of a drug which will be available in India shortly, or it has been already available in US, is a combination of a phentermine and topiramate. This topiramate is This topiramate is already available in India, but phentermine in a combination has done lots of benefits. This is a second agent which has been approved of late, because after orlistat for 13 years we didn't had a good agent which was available for a long period. What it does is, when these two drugs are used synergistically, there is a benefit. There is a dose reduction of these two drugs, less toxicity. Phentermine, non-selective stimulator of a synaptic noradrenaline, dopamine and serotonin release, so it suppresses the appetite. Topiramate is an anticonvulsant. It was, as an anticonvulsant, it's used in the dosage of up to 400 milligrams. For a weight loss, we are using up to 50 milligrams per day. I am using topiramate in the dose of 25 milligrams to 50 milligrams from past 4 years with very good benefit. So what has been done? It has been studied in various clinical trials. There is a significant weight loss and also improvement in other metabolic parameters. Side effects include, depending on the component of the drug, phentermine produces dry mouth, constipation, insomnia and a palpitation. Topiramate, dizziness and a paresthesia, but it is very, very minimal compared to what has been seen in the anticonvulsant dosage. So, though the labeling tells that heart rate monitoring is a must, but better not to use somebody who has got a recent CVA or unstable coronary artery disease, to avoid pregnancy in a woman who are taking this drug. This is the weight loss, what has been seen with a combination of a phentermine and a topiramate, significant weight loss at the end of 1 year. Yeah. Next class of drugs which has already been available and it will be available at a much higher dosage is GLP-1 receptor analog, that is liraglutide. It's a long acting. The homology is similar to the human GLP-1 to the extent of 97%. But for a diabetes, we are using up to the dosage of 1.8 milligram. For a weight loss, we will be using up to 3 milligrams of liraglutide. Has shown up to 8% of a weight loss when it is used for a period of 1 year. About 60% of the patients in a clinical trial lost more than 5%. Well tolerated. Initial few weeks can have some nausea and vomiting. Subsequently, they tolerate the drug well. Though the theoretical concern of a pancreatitis, medullary thyroid carcinoma do exist, but as of now, FDA has told not to worry about these things. Keep observing for these side effects. This is the next combination which is approved by FDA. This is naltrexone and the bupropion sustained release combination, approved by FDA recently. And Contrave is the one which has been, it's a trade name and it's been studied in the clinical trial. The dosage of 32 milligrams and the 360 milligrams used, and it is a reuptake inhibitor of a dopamine and a norepinephrine, whereas naltrexone is an opioid antagonist. Up to 5 kg weight loss they have seen in a clinical trial at the end of 1 year. Nausea, constipation, headache, vomiting and dizziness being their side effects. So, these are all the only limited drugs which have been approved for anti-obesity, but there are many off-label agents which have been approved for other conditions, but they do have a weight loss effect. These are being fluoxetine. It promotes weight loss, but maximum up to 6 months. Subsequently, there is no benefit in the long-term use. Your bupropion has also got some amount of a weight loss. Up to 4 kg they have lost the weight when they used in the dosage of 400 milligrams. Metformin in a selected patients, there is a very good effect. It's though off-label for obesity, but in a pre-diabetes, somebody who has got a metabolic syndrome can be used to a good extent. Zonisamide is an anticonvulsant that has also been used in the doses of 400 milligrams, has got benefit of a weight loss. These are a short-term drugs for 3 months you can use for a weight loss, but none of them being sustained and used for a longer period. That's why I am not discussing these things. Yeah. Recently from Endocrine Society, we had a guideline for the anti-obesity treatment. The highlights for the guidelines being lifestyle management as a first therapy, use only approved anti-obesity drug, use off-label drugs only to the well-informed patients, assess efficacy and safety every 3 monthly. If it is ineffective at the end of 3 months, better to discontinue the drug. These are the potential future drugs. I don't think it will be available in India for next 3 to 5 years. If at all it comes, very few will be available. To conclude, obesity will be a global public health crisis. Lifestyle modification has got a limited response. Safety issues throughout the long history of anti-obesity drugs. There are few new entries for this group, but concerns do continue regarding the efficacy and the safety of these drugs. Host of new anti-obesity drugs are in the pipeline, but how many make it to clinical practice, only we have to wait and watch. Thank you for your patient hearing.